Okay. Let's see. Okay, so I can go ahead and get started then.
Absolutely. Thank you so much.
Okay, so I'm following the format that we received. So my questions about this case is, it's the thoughts about using gabapentin for patients with alcohol use disorder and benzodiazepine use disorder that are on Suboxone. And also treating multiple addictions concurrently, in this case, alcohol use disorder, opiate use disorder, and benzodiazepine use disorder. Like, sort of what is the standard of care? And also wanting to know if other people are familiar with using aldactone for treating patients with alcohol use disorder. So the patient's a 30-year-old readmission to our program. He came back into our program 1 month ago. He was discharged 4 months ago after he submitted synthetic urine 4 different times. He went to the other program north of us, and he was there for 4 months, but he left because he felt he was being discriminated against because he continued to use benzodiazepines and alcohol occasionally. Up until that time, he had been in our program for 15 months. So he continued to use benzos, alcohol. He was using benzos, he said, 2 to 4 times a month, alcohol, about 9 standard drinks per week, and using marijuana 2 to 4 times a month. And he said he was doing that because he was really anxious. In the past, he used IV drug use 6 years ago. He'd never been any inpatient treatment. He was on outpatient treatment in Clarksburg, and he went to Maryland for 8 months in both of those programs. He currently has his own home cleaning business. He doesn't have any employees. He was in a relationship. Now he lives alone. He's got a positive family history of addiction, and he started using substances about age 16. Prior to our discharge in July, we talked to him about medications for alcohol use disorder, including acamprosate, antabuse, and Neurontin. At that time, though, we got the synthetic urine came back, and so he got discharged for the policy. When he got discharged from our program in July, he was on Suboxone 16, clonidine 0.2 milligrams twice daily, Zoloft 75 milligrams, and Norvasc 5 milligrams a day. When he came back into our program, he'd ran out of the Norvasc, the clonidine, and the Zoloft, and he was only taking the Suboxone. So when he came back into the program on November 1st, we restarted the clonidine, the Zoloft, continued the Suboxone, and I changed the Norvasc to aldactone because I'd read some studies where that it helped reduce people's cravings for alcohol. So he came back November 8th. He seemed to be more motivated to stop using the marijuana, the alcohol, and the benzos. And at that time, we started him on gabapentin 100 milligrams 3 times a day, and we explained the risk of using gabapentin with the other substances. On November 15th, he said he drank once since he was here. He used Klonopin once, but he didn't take it in close proximity to the gabapentin. His drug confirmation testing came back, and he had ethyl sulfate. Otherwise, everything came back that was expected. So I increased his gabapentin to 300 TID. November 22nd, he had an excused absence. Then on November 29th, he came back. He said he had no benzodiazepines for 2 weeks. He drank twice. And one night he woke up in the middle of the night and took a old prescription of Phenergan to help him sleep. He said his cravings for alcohol were less. He was less anxious. He was drinking less, and the quantity, and this was all self-reported, that he was less drinking and the quantity he was drinking was less. And he hadn't had any THC for like 3 or 4 weeks. And that confirmation testing showed that he did have Xanax, and he still had the alcohol metabolite of ethyl sulfate in there. So let's see. So his problems, comorbidities, he's got hypertension, generalized anxiety disorder, opiate use disorder, alcohol use disorder, and benzodiazepine use disorder. Physical exam and labs, he's a healthy appearing 30-year-old. His blood pressure is well controlled with the aldactone. He finally had labs and chest x-rays done, and they didn't show any concerns. Everything was normal there. Let's see. So our plans were to increase his level of care to PMAT, to insist that he have a recovery coach, require him to have individual therapy, and I was going to consider increasing his gabapentin up to 600 milligrams 3 times a day, the maximum dose that I saw in my studies and research of it. So not to get into it, but I did write a few studies down if anybody was interested about using the aldactone, and also studies that using the gabapentin to help people with benzodiazepine and alcohol use disorders. So I just interesting to see how other people felt, and that's open up for questions.
Thank you so very much. Go ahead and unmute if you have any questions for Dr. Gorby.
Yes, this is Shelby Stevenson, and hold on, let me get my video there. How does the use of gabapentin help with benzodiazepine use disorder and alcohol use disorder when it's sometimes used a lot for pain control? Could you kind of summarize some of the studies you've seen?
Yeah, so some of the benefits, and this was done by an NIH government study, that just some of the benefits and some of the risks. The GABA alleviates restless leg syndrome, the Neurontin alleviates restless legs, certain types of headache, neuropathic pain, achiness associated with withdrawals. It said it absolutely decreases the anxiety, which helps for people that are going through withdrawals, and part of the reason I think that they're using the alcohol and the benzos. It treats pain and it reduces risk of seizures. And it definitely doesn't have the same risk as other substances like opioids. The dose needed to produce the desired euphoric feelings is like 33,200 milligrams. Sometimes it could be considered a gateway drug to relapse. That's one of the downside of it. It does potentiate the effects when used with other drugs. But the study that I was looking at, it said there's limited randomized clinical trials have been conducted which demonstrated therapeutic uses of gabapentin in substance use disorder treatment. And that was Mason 2018, Mason and all 2014, and there was a Mohignum and Alvenia in 2013. And GABA blocks the release of brain stimulating chemicals, raises serotonin, and helps to stabilize the GABA glutamate system transmitters.
Okay. Okay, thank you.
You're welcome.
Can you say more about aldactone and its treatment with alcohol use disorder?
Yeah. So last year I went to ASAM, and the guy presented that study on aldactone. So I thought it was pretty fascinating. So I started using it some in my practice, and it does seem to be pretty effective. But the studies there was one listed in molecular psychiatry, and it was a study done by the NIH in September 20th, 2022. So it said mineralocorticoid receptors. It regulates fluid and electrolytes, and aldactone blocks these receptors. In the mouse study, it said that the higher amount of aldactone, the decreased alcohol the mice took in without any adverse effects on the mice. And there was a study done at the VA, which showed the Veterans Hospital showed a significant association between aldactone and reduction in self-reported alcohol consumption. So it seems to And I've tried it on 3 or 4 people, and it seems to definitely cut down on their cravings and their alcohol consumption.
That's awesome. What dose have you been finding effective?
I usually start off on 25 and probably stop around 50. I think in some of the studies that they went up maybe higher to 100 or 200.
You know, that's interesting. A study found that because a lot of patients with alcohol use disorder subsequently have cirrhosis and, and decompensated ascites, and we often use spironolactone with that and aldactone interchangeably sometimes. And so that's interesting to know. Thanks.
You're welcome. Thank you.
Thank you so much for those excellent questions. In case, do you have any other questions, anyone, or comments that you would like to make before we move on?
I have a question. Dr. Gorby, you said you're moving the patient to PICO. What is your PICO? What is that?
The PMAT.
A PMAT, yeah. What's that mean?
So he has to come in weekly for regular appointments. So the regular appointments, there's a meeting with the therapist, and there's a meeting with medical management, and then there's a 12-step meeting, and then he has to come in another day of the week, and he has to give a drug screen that period of time as well. And he's been really hard to get him to do like, it's really been difficult to do like individual therapy and stuff with the therapist. He says he just can't because he works so hard, and he doesn't have anybody to help him.
And he doesn't see his alcohol use as a problem at all?
He is not, yeah, that's a good point. I was able to motivate him to quit the marijuana because, I told him it lowered his IQ and it lowered his motivation. And he did stop the marijuana. And, but the alcohol, he still has a hard time seeing that it's a problem, even though I've tried to motivate him, and the group's tried to motivate him too.
I'm impressed that you got him off marijuana.
Thanks.
It's a challenging case.
Yeah.
Thank you, Tony. Did you have any other questions, Dr. Garby, for the group?
No.
It was really interesting. Are you sure?
Yeah, I'm sure. Well, yeah, I guess I do. Has anyone else heard about the aldactone, and is anybody else using gabapentin when they have a patient with comorbid conditions like alcohol use disorder and benzodiazepine disorder? So basically, the point I guess I was looking at is, we're treating multiple addictions concurrently, like polysubstance use disorders, and using different medications to treat those disorders. And I just wonder how other people were approaching that.
Yeah, this is Marianne. So I have not used aldactone for alcohol use disorder, but I think that's really interesting. As for the gabapentin, I'm pretty leery about that, to be honest. I have one patient who has had in prolonged sustained recovery, who's got over a year of sobriety, who has significant neuropathic pain. And he has not been on gabapentin, but he has kind of suffered with his continued pain. And so since he's done so well in recovery, we did initiate him on gabapentin, but I actually took him out of group, and I'm seeing him individually. And he maintains a really active support in AA meetings and NA meetings locally. But I also didn't want, part of the issue becomes, especially in other folks, then it becomes, oh, well, I have this, I need to be on gabapentin, and there is abuse potential with it. And we know that combining it with Suboxone can be potentially dangerous. So I'm pretty leery as far as the gabapentin goes, especially someone in early recovery, someone with more sustained recovery, maybe. And if they just have alcohol use disorder, then I certainly may use gabapentin, but it becomes a little trickier when you combine a Suboxone. So I guess I'm just a little leery about prescribing medications specifically for each substance and trying to look at it more as an overall addiction, and how can we better treat that?
Appreciate that.
So I've used gabapentin for those with alcohol use disorder as well as opioid use disorder. And the gabapentin mostly so to help control cravings for the alcohol. And the patients are on Suboxone and have had pretty good outcomes with that. I've also used it in combination for people with opioid use disorder and peripheral neuropathy, and they're fine. I have actually never used it for those for benzodiazepine use disorder in combination with alcohol use disorder. Yeah, so thankfully I haven't had any bad outcomes in terms of combining gabapentin and Suboxone. But then again, in West Virginia, we have a pretty low dose of Suboxone, right? It's just 16 milligrams, whereas in other places they go up as high as 32, many other places.
Thank you.
I would be curious to see those articles. If you can pass them on to Elizabeth, that would be really, those studies, that would be really helpful.
Okay.
Yes,
I mean,
please.
that tone is especially surprising, right? Because we have so many people with alcohol use disorder on spironolactone and Lasix, and they have not seen benefit that way. So I wonder, maybe it's timing on catching it. It makes me wonder when is the best time to try it, initiate it, and see.
Great, thank you so much. Great discussion, guys. Appreciate it. Anybody else before we move on? All right, thank you again so much, Dr. Gorby. And yes, pass those articles my way, please. All right, Jennifer, are you ready?
Yes. If you can bring up the 57-year-old first, if that's possible, Elizabeth. I don't know if it is. Oh, good. You're good. So if you could scroll down before we get to questions. So this is a 57, oops, wait, sorry. Yeah, general assessment. So this is to me, a really interesting case. This is a 57-year-old Caucasian female on Medicaid who came into our program 2 weeks ago. She came into our program actually because her husband has been successful in getting off opioids and onto that he was getting on the street and taking Suboxone, and has done really well. He's about to graduate after 90 days. So this lady has been taking Suboxone 8 milligrams twice a day and Klonopin. What she says is Klonopin, and I believe her. I can get to that in a minute. 0.5 BID for about 18 years, buying it on the street or buying it from someone she knows. And she originally started Suboxone because she had had a car accident and she was prescribed oxycodone. I don't know how long she was on that, and wanted to get off it. So she started just treating herself with Suboxone. She started Klonopin to treat anxiety, and it has worked. So she came in, she wanted to be on our program because she said she was starting a new job and she wanted her prescriptions to be legitimate, and she was being truthful with her employer about her use, and was going to be able to get this job, but had to have prescriptions. So she lives with her husband. I talked about him. She also lives with her son, who is not aware of either her use or the husband's use, the father's use. And she did not want him to know. So the first day I saw her, she was petrified because I told her that I wasn't going to be able to prescribe the Klonopin along with the Suboxone because of the risks. And she just was immediately terrified and weepy. I did reassure her that I wanted to help take care of her and that that we could make a plan. So Elizabeth, if you could go back to the top. That day I talked to our psychiatrist on staff, and he agreed can't continue the Klonopin and the Suboxone. He wanted me to taper her what seemed pretty quickly to me, over a week. and he gave me a little schedule. And at that time, she had what she called a lot of Klonopin at home, and had no Suboxone. So I didn't prescribe Klonopin, but I asked her to cut the 0.5s in half, and I decided just to taper her more slowly. So I asked her to take a half BID for 5 days and come back in, and we would monitor how she was doing and monitor her urine. The first day I saw her, her screen was positive for Suboxone and benzos. That day, her confirmation, when it came back, interestingly, this is a little bit strange, it was positive for lorazepam and for the whatever is the metabolite of Klonopin. So at any rate, so that very day that I saw her, that she was so upset, I continued her Suboxone. I asked her to cut her Klonopin in half. I started her on buspirone, 5 milligrams TID. And before I did any of this, I offered her inpatient detox, and she declined. And I talked about why that was actually safer, but she declined. So she did come in 5 days later, and on that day, she had self-tapered her Suboxone to essentially 12 milligrams a day from 16 milligrams a day. And she said she felt fine. She had started to taper the Klonopin as I asked, but she had a hard time with it. So she had actually, instead of going to 1/2 BID, she was on a half in the morning and a whole at night. And she was taking the Buspar as directed. She came back in, which was really good. So when I did actually telehealth with her that day, and I said, stay on that lower dose of Suboxone, 12 milligrams a day. And I asked her again to try to cut back on the Klonopin, and I was going to see her 48 hours later in person. I also had her increase her buspirone to 10 in the morning and 10 at night and 5 at midday. So I saw her after I filled out this case form. I saw her again on the 7th, and at that time she had tapered down on her Klonopin to 0.5 BID. She continued on 12 milligrams of Suboxone and was doing fine on that. Interestingly, that day her screen was negative for benzos, which is interesting. The confirmation came back and had clonazepam and the metabolite of clonazepam, so the confirmation still showed. She felt like the buspirone was helping, and she was motivated to continue in the program, and was not as petrified as she had been on the first day. So that's the basics of the story. My questions are, I'm doing a much slower taper than was recommended by my psychiatric colleague, who I respect, but she's working with me and tapering. My other question was about tapering Suboxone. I do have her scheduled with the psychiatrist in about 3 weeks. That was the soonest opening, but it seemed like another option that if she can eventually taper off Suboxone, maybe we just treat her for anxiety with benzos or have the psychiatrist treat her. So those are really my basic questions that I wanted a little bit of feedback on. So far, I will just say that this lady seems pretty, I just sense that she is trying to do the right thing and trying to work with me, and is not, but she's following my recommendations as best she can and telling me the truth. I think that's the story.
Thank you so much, Jen. I kept some of those questions up there, but for a little bit, so please do feel free to unmute or ask further questions.
I see my other questions on there that I had forgotten. One was, should I continue to see her twice a week? And I actually did not see her. I just waited a week this time, and that was partly because I could see that the benzo level was dropping. So that's another reason that I trust her. And then could I continue to increase the Buspar? Was another question.
Jennifer, are you prescribing the Klonopin, or is she still buying them on the streets?
No, so she, the first week she had enough to last until she came back to me. And now, and she actually brought her last tablet in. So I also confirmed with our pharmacist that that was indeed, I mean, the urine showed it too, but at that time I didn't have the urine results. So it showed that it was Klonopin. The pharmacist confirmed she was out of it. So I gave her enough for this week.
Okay, but also to let you know that a lot of times on urine drug screening, Xanax and Klonopin don't show up. It's not so.
You have to order it. On screening. Okay, yes, that's why I'm getting the confirmation every week.
Good. I think it would be, something to long-term benzodiazepines is probably not a good idea. You mentioned maybe switching her, getting her off the Suboxone, because long-term benzodiazepines increase your risk of falls and early dementia. So probably be safer to have her on the Suboxone, in my opinion. And I think this, in my opinion, this would be one you could consider the gabapentin. I think. Thanks for letting me share.
Interesting. Thank you.
I'm driving. Otherwise, I would put the video on. I don't want to scare anyone. So with the benzos, I think with Klonopin, I mean, trying to reframe it where it's, some people feel like benzos are the ultimate treatment of anxiety when they're really not. They're meant to be a shorter term thing. So framing it more like, hey, we'd like to get you on effective anxiety treatment, because ultimately benzos rarely prove to be effective long term. I think if she's been on it for 18 years, 0.5 BID of Klonopin, that's equivalent, depending on the person, to like 2 to 4 milligrams of Ativan daily for a long time. If you need to extend it out a little bit, I don't think there's anything wrong with that. Like if she shows up and she's still feeling a bit rough, like a 1/4 milligram at night is not a huge dose. Transitioning to gabapentin is a bit tricky, because we know that gabapentin with Bup isn't great. The Buspar, you can certainly titrate that upwards as much as you need to, basically to 60 max a day. You may want to consider an SSRI too. I jumped on a little late, so I don't know if she's already on an SSRI, but that would ultimately, that combined with the Buspar would probably be the best treatment for anxiety conditioning therapy. So I hope that helps.
That is excellent. That answers all my questions. And I actually, hadn't thought about an SSRI, but so that's a good reminder. That's excellent. Thank you so much. You got it all.
Thank you so very much, everyone. Any
Hi,
other
Jen. Oh,
Tony? I see, yes, Dina, and I see Tony.
hey, Jen, you did an excellent job collaborating with your patient, having her come in, meeting with her frequently, getting her to be honest. That's amazing. And yeah, and I was just going to say similar things. You might find that you may take a little longer to take her off that benzo, and don't feel bad about that if that happens. And yeah, starting SSRI will be awesome for her if she's willing. But you know what? When you talk to her, just kind of pitch it as shared decision making, which I'm sure you do already. But it's really important you do educate her about long-term effects of benzos, because most people don't know that. And in fact, most physicians don't know that, right? They think they think it's the best treatment ever for anxiety, when it's not. Yeah, but man, that's an amazing job you did with her.
Oh, thank you so much. And thanks for those suggestions. Yeah, my main goal with her was to keep her in care. And this past week, what I said to her was, it's risky what you've been doing, and it's more risky now than ever. And she said that she was terrified. She said she was well aware of what she was doing and I was just meaning buying it on the street. And and in fact, it was pretty interesting because when she was in group with everybody and I was letting people know what was in their screen, when, you know, they thought they bought meth and there was ecstasy in it, or they thought they bought fentanyl and there was meth in it, she was looking at people going, really, really? So I think that reinforced for her the importance of her being in care.
And I wasn't going to give any other recommendations that haven't already been shared, but just wanted to reiterate like how great you did establishing such a therapeutic, trusting relation, especially for someone that seems so scared. I'm sure that was really frightening for her to think about not being chemically managed by stuff that she's been using for years. So good job on developing trust so quickly.
Thank you. I appreciate that. Her husband probably helped too. He's a fan of our program, so I'm sure he supported her. And actually, her cousin is in the program. I heard them saying "I love you" when they were leaving. I was like, "Why are they saying I love you?" She said, "Oh, that's my cousin." I was like, "Okay."
That's excellent. Thanks so much. Jen, I know we have one more case, but in the interest of time, is it okay if we do it the next time? Or if it's urgent, I don't mind sending it to the hub as well.
Let's do both. If you could send it to the hub, and then I'm happy to present next time.
That'd be excellent.
Thank you. Thank you, Elizabeth.
Of course.
And everybody.
All right, Sarah, I'm ready to share your slides and just tell me when you're ready to advance them, okay?
Sweet. Awesome. So I'm Sarah. I'm a clinical therapist at Chestnut Ridge, or Healthy Minds Chestnut Ridge with the Department of BMed. So I'm going to talk about veterans and addiction. I will try to make it super fast because I can talk forever on this subject. So there's all my alphabets after my name, and I have special appearances from the Animal Friends of North Central West Virginia this time. So next slide. So just a quick disclosure with Stanley Yelnats. I have no idea why they named him Stanley Yelnats, but I figured he needs to be the first one on here because of his name. I have no financial gain, no conflicts of interest, nothing like that. Next slide. So real quick trigger warning, I will be talking about violence, some politics, rape, death, suicide, killing. We're still working on the LGBTQIA Two-Spirit Plus kind of element of veterans and being in the military. It's been a very controversial topic, just even in my short time in the military and also being a veteran. So like we first had Don't Ask, Don't Tell, and then we repealed it, and then transgender. So like it's the picture that we have isn't exactly fully clear of what it is. And so I also want to take this time to recognize, you know, gender versus sexes. Like I do use male, female for the most part, kind of to quickly touch on what different genders there are. I use the term soldier universally because I was in the Army, but I want to take time to recognize that there's airmen, seamen, Marines, like there's a whole bunch of different terms for different ones. It's just I default to soldier. I curse. I try not to curse, but I trust in your ability to cope with it. There are other free mild trainings if you have an issue with it to learn about veterans. Please go to those links. Next slide. So I was deployed to Afghanistan and Iraq. Here's a few little pictures of me from a lifetime ago. I got my MSW from Boston University. My husband is a former Marine. I have friends in all different branches and all different jobs within the military. So next slide. All right, so we got Crazy Cora joining us today, but we have to, if we're going to learn about veterans and addictions, we have to understand put it in a little bit of context. So knowing kind of what is part of military culture, especially not just when you're deployed or you're active duty, but this is also a big piece that we see in the National Guard, reserve branches, stuff like that. So we know that a lot of people who do join the military are of a lower SES, socioeconomic status, where they're low income. A lot of times their parents aren't normally graduates of college. We have seen an increase of people going and joining the military for the
Yeah, do you want to do it tomorrow before this?
we do see a lot of people joining for college money and to fund their education. There is the largest population of people that join the military are the indigenous Americans. They have the highest rate per capita of people who do join the military, and most sources and most people believe that this is coming from, it's part of their culture to kind of be a warrior. And plus we also have to recognize of, their life on the reservation may not be what they hoped it could be. So another big part of military culture is trust. And obviously, like, if you guys have any questions, please ask as it goes on. I don't know what other people don't know, and because it's a life that I've lived. I joined the military when I was 17, so I've been either a veteran or in the military most of my adult life. So it's really hard for me to not know what, like, I take for granted what I do know. And so if there's any questions or anything, definitely feel free to email, put in the chat, whatever. There's a lot of trust in the military. I'll touch on this a little bit later, but you have to trust the person next to you is fighting just as hard for your life as you are fighting for theirs. So, like, there has to be that kind of cohabitation of trust and co-facilitation of knowing that everybody's working together, because mistakes can be deadly. There's a lot of training that goes into the military. That's a big part of it. And that's why, basic training, boot camp, whatever people tend to call it, that's one of the major foundations that's kind of generalized each branch has their own, like, basic training, boot camp, whatever, but it is generalized between whatever branch it is. So they normally have basic training, and then there's the higher level of education that is kind of job specific. There is general rivalries between the branches. There's a lot of kind of shit talk, which I'm great at personally. I'm very good at shit talk. So it's one of the things that a lot of veterans and former military kind of rib each other for. A lot of issues around death. We know that this will come up later in the suicide part, but we know that a lot of people who are exposed to a lot of death have higher rates of either suicide attempts or completed suicides. And so, like, there's kind of like that almost dialectic existence where you never expected to live, but here you are living life. And so, like, that can cause a lot of conflict. Also, PTSD is pretty universal. It's been written about since the times of the ancient Greeks. Homer has notoriously wrote about that in the Iliad and the Odyssey. And another part of it is, I touched on a little bit, is the mistakes. We know that if we make mistakes, we can hurt, like, some people can get hurt. And so a lot of times veterans can be very, very sensitive towards making their own mistakes. When I say sensitive, it's likely they're going to be hard on themselves. So there's a lot of kind of issues with that. And, a struggle with incompetence, I'd almost say. So when other people also make mistakes, because it's kind of pounded into our heads that mistakes get people hurt. Next slide. So I just want to briefly talk about, like, early Korea and Vietnam veterans. That's kind of the last wars, conflicts, police actions that we've had with the draft. A lot of Vietnam and Korea veterans that I work with, they're very conflicted because they don't feel like they fit in with the kind of crowd of veterans because of the political conflict that was going on when they first came back. And so when we talk about the draft, we have to look at when people are kind of drafted and deployed versus units. We're more focused on deploying units now, and for overall purposes, we're deploying units versus single individual people. And so when that kind of shifted, it really works with how people kind of adjust when they come back home, which we'll talk a little bit more about that. With Korea and Vietnam, there was a really unique shift when it came to not just how civilians and veterans and everybody, but there was a big shift when it came to the media trusting what the military was putting out and what the government was putting out. So like, I believe, especially after World War II and everything, that shift really kind of was a big, I believe, a big shift in the American history and how we work with the government. The Korea and Vietnam was also the first conflict kind of area after World War II where there was fully integrated forces. So this is a new thing where we have people of color serving with people who are identifiably white. And so that kind of unique aspect of it definitely shifted the social dynamic, in my opinion, to how different branches are kind of run. So the really unique thing that's kind of happened in Korea and Vietnam is that substances were widely available during these deployments, for everything from heroin to alcohol. They were very, very, very widely available. And so it's a rough estimate that while serving in the Korean and Vietnam conflicts, there is roughly 20% of soldiers that identified being like classifying themselves as addicts while serving. But when they came back, it helped us understand addiction a little bit differently, because when they came back, the people who classified themselves as addicts, they didn't have kind of reuse once they came back to home, once they came back to America. And so they didn't have the continued use of alcohol, or, well, I mean, some did, but they didn't have the continued use, especially of heroin, because a lot of times this is the first exposure to any sort of like harder substances outside of alcohol while being deployed. And so that really helps shape how we understand addiction, not just in the veteran realm, but in society as a whole, because it's helped us understand a little bit more on how connection and environment influences addiction. And so like that 5% rate of people who did end up using, and I think the study went for roughly a year after they returned home, only 5% continued with their use. And that's pretty significant. And it taught us a lot about how that kind of works together. So next slide. So we're joined here by Molly. Molly is going to tell us about OEF, OIF, and Operation New Dawn. So these are kind of the first time, and the Gulf War is kind of lumped in here too. But this is the first kind of time where we have a full voluntary military service. And so like everybody in the military as of right now is fully voluntary. And we also have had the higher use of contractors. So like Kellogg's, Brown and Root, just different contractors that are also doing military style jobs. And so like that was definitely a shift in how war is fought and how business is kind of done while deployed. We do have a higher use of technology as well. So while deployed, we have more access to social opinions, more access to keep in touch with our families. And, we have smarter weapons. We have smarter ways that we utilize those weapons, from everything from missiles to drones. Technology has really shifted on how we fight wars. And then we also have the social influences of 9/11 and going into Iraq with weapons of mass destruction. There's been many studies that show that after 9/11, veterans that were already utilizing VA services reported less symptoms of PTSD, because there is that unified piece where everybody's in it together as we move on after 9/11. And so when we have this kind of community-based trauma, for lack of a better term, we tend to kind of have that feeling of we're all in it together. And this is something that we've seen replicated in Bosnia during the Blitzkrieg. We've seen this replicated time and time again in communities that have a universal trauma. And when we kind of all go through it together, we have lower levels of PTSD and PTSD related symptoms. So next slide. I'm trying to keep it on track here. So now to the meat and potatoes. Alcohol, substance use, all this fun stuff. So alcohol is one of the main things that a lot of veterans use. And I think it's mainly a large percent of it is because of availability. We know that American Legions, VFWs, they all have, most of them have canteens. That was actually my job before I became a therapist. I was a bartender at a VFW, and I figured I already had the experience of being a behind the bar therapist, so might as well dance with the one that brought me. So when we have alcohol involved, it definitely we know that it increases our PTSD symptoms, and increases how we it complicates how we interact with each other. And the rates of addiction are definitely there. And the more we kind of talk about this stuff, the more that it gets a little more convoluted, which I don't think is a surprise, because there is a huge element of ritual when it comes to remembering our brothers and sisters that have passed on, either in combat situations or they weren't able to handle life after they returned. And so there are a lot of rituals where, you know, you set a beer out on a table, or you set a beer out on the bar, and that's for the people who haven't come back, or, you know, couldn't sustain life after they came back. And so there's a lot of rituals that kind of survive with that whole alcoholic element. We know that people who have been in combat have higher rates of alcoholism. Males do tend to report consistent rates of alcohol use disorder, especially older vets have a higher rate of alcohol use disorder versus the civilians of the same age. However, females tend to have more binge drinking kind of behaviors. And so when we have that kind of piece to it, it might be, we have that socially acceptable piece where males might be able to feel more comfortable potentially going to a VFW, versus females, that kind of binge drinking behavior can be very, very difficult. While you know, the Department of Defense is very much combating what happens while we are in active duty, but there is a lot of binge drinking, a lot of hazing. There's a lot of stuff that kind of revolves around alcohol, and that includes people who are of underage, because you can join at the age of 17, which is what I did. And so we have people being exposed assuming that they weren't using anything before, but there's people who may have never been exposed to something like alcohol or cocaine or different things like that at a much younger age. And it's a very much a binge drinking kind of environment, a little bit like college. So then we move on to marijuana. So marijuana use in veterans has definitely been increasing, especially with availability, medical marijuana. So a lot of that stems from trust. When it comes to being prescribed different opioids or benzos, a lot of that kind of the way that the opioid epidemic has definitely hit West Virginia, a lot of more people are using marijuana to kind of combat the PTSD related symptoms. And so we've seen an increase of 56% between 2013 to 2019. So that's a pretty significant jump. And I bet you that we've seen a higher jump, especially once we entered into the pandemic. And as it does become a medical use within multiple different states. I've seen it here in our state too. So then we move on to the VA. When people were first initially coming back, it was a very much crisis stabilization mode, where we have a lot of people coming back with these very significant symptoms, and we kind of used what we could use it as fast as we could use it. And so a lot of opioids, a lot of benzos were prescribed, where, you know, as we've learned, because medicine is a practice, as we've learned, we've kind of been able to step that back a little bit and learn more about different ways that we can kind of manage some things. Tobacco is definitely a big thing. I know I've smoked for 1 week in my life, and that was the first week I was deployed to Afghanistan. And so it's definitely something that's very much normalized. Like, smoke them if you got them is kind of like the term for if you have a break. Like, let's smoke cigarettes because there's nothing else to do. There's a lot of downtime in war, ironically. So when we kind of use that, it's a boredom killer. And same, there's also significant use of things like whippets. There's significant use of cocaine, just things that'll help try to keep people awake or calm them down real fast. And so obviously the DoD is working on combating this stuff, but we're working on, there's lots of room to improve. So real quick, next slide. All right, so there's definitely other addictions that occur in the military. We know that sex addiction is a big thing. Adrenaline addiction, that kind of risk-taking behavior, is definitely higher associated with PTSD. And the type of people that join the military already kind of get that taste of having that rush of adrenaline, especially if people have been deployed, because there is definitely an element of the rush to when you're in a firefight or when you're doing convoys, things like that. So like that adrenaline and seeking that kind of adrenaline has definitely sought to replicate when they return. So we have people doing, relatively healthier and safer things, but it's things like skydiving or whitewater rafting or, driving motorcycles really freaking fast. So there's definitely an element where that adrenaline seeking behavior is replicated when people return. Gambling's another one. Work addiction is a real thing as well. When we know that when we have people who have complex PTSD, they either kind of go one of two ways. They either turn into a workaholic, or they kind of jump from job to job to job. So a lot of times that kind of drive to do better and do well is a big part of an addiction where work is their life. There is speculation that the thought of being in war has addictive-like complications, and it's not something we can always study per se because it's such a small population, but it's also such a complex thing because on one hand you miss war because it's simple and it's us versus them and it's very compartmentalized. There we go. But it's kind of a faux pas, like it feels socially wrong to say that I miss being in war. And so like and plus we know how our brain lights up and adrenaline gets going. We know how all the flight, fight, or freeze kind of activates our feelings and how we react to things. And that can kind of get us in that cycle of feeling addicted to being in war. That's why we do see a lot of people go back after they've been deployed, go back and do things like the contractor work that I was talking about beforehand. So next slide. Oh, so there's a bunch of compounding factors. So we know that societal perspectives, there we go, or perceptions, we know that has a big factor on how we feel about what we've done. And so that kind of ties into that moral injury where we might have watched the death of unmarked combatants, or we've watched children and women die. Like when there's unmarked combatants, everybody can be a combatant. So it's easier to make sure that we take out people who may be a threat versus letting the people next to us die. And so that kind of ties into that making mistakes. So if we say, oh no, that's just a boy playing ball, but if that doesn't come off initially as the perception of what that is, it might end up in somebody dying. And so like that's kind of the hard part about our brain, because the way we perceive threats is so fast that there's very little judgment in it, because we've been trained so hard to react and not think before we react. And so that's something that we see replicated time and time again by people who have some of the highest military honors, like Purple Hearts and Bronze Stars. Audie Murphy said after he took out a whole company of Nazi soldiers, he said, the reason I did that is because they were killing my friends. He wasn't thinking, oh, I might die. He was thinking, oh, they're killing my friends. And so a lot of people react before they think about what they're reacting to when we're kind of in that situation. So suicide's a thing. Reintegration is definitely, they train you up to go and do war and all these other things, but they don't teach you how to come back. They don't deprogram you. That doesn't really happen. So that's why it's important to know about this stuff. Suicide, it's definitely a big thing that we've been combating for a long, long time. And there's definitely still room for growth. And I think talking about suicide, and especially those who have had suicidal ideation, it kind of becomes a chronic thing. And if we don't talk about it, I think it makes it more likely for people to not reach out when they're at that point of attempting suicide. Military sexual trauma, MST, that's another huge factor because there's a lot of guilt and shame associated with that, especially for males that have had experienced MST. There's the stigma, LGBTQIA+. I think we're going the wrong way. You're good. Go back one more. So we know that I talked a little bit about brains. So our Broca's area, the way we communicate about what's going on when our brains get activated into go mode, that Broca's area that helps us communicate, it turns off. So words, making words and finding words to describe what's going on, it shuts down. So that's why there's a lot of emotions and flashbacks. There's not a lot of words to put with it. So when we work with veterans, it's hard to help them find their words. And so a lot of times finding different ways to express those emotions or what's going on with it might come in the form of art or, I don't know, interpretive dance, whatever it is, get it. If it helps people express themselves, whatever, get it. Sometimes woodworking, whatever. So smells are really important too, because the smells that are associated when you are a veteran are quite different than what you normally smell in the civilian side of things. So like, burning flesh, different things definitely have a very distinct smell. And so when it does happen in the civilian side, it's very, very triggering. Compartmentalization, there's that word. Treating with civilians. So the thing that we know when it comes to civilians treating veterans, we know that it's very, very hard to get rural vets into services because of the lack of internet connectivity and just services in rural areas. It's the same thing that we see a lot of times too in civilian side of things. So another thing is burdening other with my trauma. Well, it's damaged me, so I don't want to put it on you because it's going to damage you too. And so a lot of times veterans struggle to share their stories because they don't want to burden others. Vicarious trauma is another thing that we need to look out for. So when we're treating veterans, we need to make sure that we're taking care of ourselves. Next slide. So we are doing better. We're recognizing that, we need to give veterans space to talk about these things and create a community kind of environment where we're all taking care of each other a little bit more than what we were. Looking at it in a holistic way where, we're making sure that your basic needs are met. We're making sure that you have hobbies. We're making sure that you have the connections and growth that you might need. We're talking about it more, which helps facilitate post-traumatic growth. We're having, just even having this portion of ECHO is a very important way that we learn about this stuff and have a platform to ask questions and other things like that. We're getting better at having peer supports for veterans. We're expanding services for rural vets. Roughly 70% of rural vets do not have access to mental health services, but we're getting better, thanks to COVID, for having more internet services available. Also, vets are notorious for having a very close and personal connection to animals. I think everybody does in a certain aspect, but I think veterans, there's just something about animals and veterans that really kind of click. Next slide. Lots of media to consider. There's really, really, really cool stuff. There's TED Talks from Adam Driver. There's Sebastian Younger does a great TED Talk. There's so many different TikToks, great authors out there. Next slide. Oh, any questions? I know I flew through that. I know Derek Silsky, he's another one of my friends that are also veteran. And so like, once we find each other, it's really weird because once we find each other, we're always like, have a little space in our heart for each of us. Like it's really weird, but good. We just have like this little space in our heart. And so we just are there for each other. It's very interesting. And it's complicated, but it can be very, very rewarding working for vets. But it takes a lot of, we know that even working with people who struggle with addiction, it takes a lot of time to get them to trust us. We have to work more on attachment. Veterans, it's even more than the regular substance use person. And so like it takes a lot of effort to get in there. So just keep trucking and be your most authentic self, because you know, we know that people who struggle with addictions can see through the bullshit. Veterans can see through the bullshit even more. So being your most authentic self is one of the key factors, in my opinion, and the ways that's definitely helped me to treat other veterans. So any questions?
Sarah.
Yes.
Number one, thank you for your service and thank you for your continued service. And having, as a veteran, I want to thank you again for doing this presentation so people understand better. Thanks.
Thank you. Thank you. Sorry it was so fast. I'm just glad that I've got it down within 3 minutes. Because I can
we
easily
can
talk.
always do a part 2 because this is so important. So yeah, you know, I know we were cutting a little short, but yeah, we can always do a part 2. It's not a problem at all. It's very important. Thank you so much. Anybody else have comments or questions? I know we're over time, but it's completely fine, you know, or any experiences you'd like to share.
And you can always email me too. Sorry.
That might be one of the most informative presentations I've ever heard about veterans. I really appreciate it. And I think a follow-up at some point would be good, just to keep honing in on veterans within our programs. Thank you very much.
We do have some of the highest rates of veteran per capita in the state of West Virginia. We have a lot of people that do join the military because we are a state that has statistically low SES. And so we can't ignore the element of service and military service within this organization. I think, and especially when it comes to spouses, like there is certain elements when people come back, and then we also have to recognize too that a lot of female veterans marry other veterans versus male veterans. I think it's 85% of female veterans marry another, or you know, partner up with another veteran. But when it comes to male veterans, I think it's something like 15% are only likely to marry other veterans. So like that part's very, very interesting to me. But
Absolutely. Anyone else before we close? Again, we really appreciate it, Sarah. Thank you. And thank you so much. Everyone, we will see you at the new year. Just want to wish you guys a happy holidays with your friends and family. And we really look forward to seeing you. We'll get some more communications as the time comes, and really appreciate everything you guys do. This is such a fun and amazing group. So we really do. You have a great holiday. All right. Thanks. Bye.